Should I bring my slides up, Eileen?
Sure. Yeah, you can go ahead and do that. We've
Okay.
done with the disclosures stuff. Great. Looks perfect. All right. Well, we have just about at 12:04, and we're already at our usual starting number. I think probably because so many people are really excited about the talk we have today. So thanks everybody for joining our Friday CFAR conference. Today we're really lucky to have Dr. Todd Brown, who I always say doesn't need an introduction, but just in case you don't know him. So he is an endocrinologist here and did fellowship training here and his PhD here in addition to his medical degree, where he cares for lots of people living with HIV, everyone we can get into his clinic, I think, but really covers the whole spectrum of endocrine expertise from diabetes to hormonal management and also bone density. And we're just really incredibly fortunate to have him here at Hopkins. So thanks so much, Dr. Brown, for joining us today, and I will turn it over to you.
Great. Well, thanks, Eileen, for the invitation and the kind introduction. So, yes, I'll be talking about diabetes today. This is, I gave a talk at the ACT HIV conference a couple weeks ago. So this is pretty much a reboot of that, but I'll leave plenty of room at the end for discussion and questions, etc. Just make sure that I can advance. There we go. So here are the learning objectives. And as far as disclosures. Okay, so why care about diabetes? So for those of you who take primary care of your patients, lots of things to worry about, but I always want to make the plug of why we care about diabetes, that it's, we all know that it's rapidly increasing prevalence, lots of badness associated with diabetes that can potentially be prevented by good control and control with the right medications. Common in people with HIV, and some data suggest that it's more common in people with HIV compared to people without HIV. And the tricky thing about diabetes, of course, is that we have decent medications to control it, but the management gets complicated and really requires individualization. So not too much about the pathogenesis, but it's worth talking about, sort of what's different in people with HIV. And so host factors are, super important. And so obviously adiposity drives, the epidemic of diabetes that we have here in the US and around the world. So the increase in adiposity. There are other factors, of course, that may play a role. So hepatitis C, untreated hepatitis C may play a role. Relatively small one, but one nonetheless that can be reversed with cure. Individual factors, of course, play a role, and concomitant medications. So this used to be super important. So I've had this slide for a long time. Some of you may recognize, but the steroid interactions with CYP3 and 4 inhibitors for a while were really important side effect. Where we would see all kinds of metabolic problems in people on concomitant PIs and steroids. Atypical antipsychotics still play an important role in diabetes among people with mental health disorders. Regarding antiretroviral medication factors, so I sort of think of these in two groups. One is groups of medications that we don't use anymore, but have legacy effects. So these include thymidine analogs, so stabudine. People who have severe lipoatrophy from stabudine, it doesn't really go away, even though people have been off it for many years. And that sick fat that's left behind can cause metabolic problems. Older PIs also probably played a role in the pathogenesis and may set people up for future diabetes. And then with the newer medications, there's been lots of talk about weight gain. There's data, including some from here at Hopkins and led by Joe Wong about integrase inhibitors and their impact on diabetes that's independent of weight. Relatively small effect, so not a huge effect like we saw with indinavir, for example, back in the day, but still something that we should be aware of. And then, of course, the HIV in and of itself, the leading, even with suppressed HIV, leading to residual activation and immune activation and inflammation, may drive both beta cell dysfunction and peripheral insulin resistance. Okay, so getting more into the clinical aspect of things. So the first question is one about screening. And I'm going to refer a lot to the standards of care in diabetes. So this is a document that's released by the ADA, American Diabetes Association, every January. And it really is, the go-to document. So if you Google it, you'll find it very quickly. And pretty much everything you wanted to know about diabetes, there's a chapter about it and recommendations about it. And so I encourage you to look at it for those of you who take care of people with diabetes, which is probably everyone. If you have specific questions, this is really the go-to document. So let's talk about screening guidelines for diabetes. And the ADA points out a bunch of different groups that are at higher risk of developing diabetes that should be screened. And so the first group, it's a large group, and people who are overweight or obese with one or more additional risk factor like dyslipidemia or hypertension, et cetera. So that group should be screened. Now, people with prediabetes, so this is people with impaired fasting glucose generally. So this is people who have a glucose between 100 and 125, and A1C between 5.7 and 6.4. People who have high random blood sugar, or if the oral glucose tolerance test is done somewhere between 140 and 200. So that population should get screened, and these folks are at very high risk of developing diabetes. And then women with just a history of gestational diabetes, very important group that can develop diabetes who are at risk. And then they have a bunch of other high-risk groups that they call out, including people with HIV. And so how do we make the diagnosis of diabetes? And so we have generally 4 ways of doing this. One is a fasting glucose of 126 or greater, oral glucose after an oral glucose load, 75 gram, typical oral glucose tolerance test greater than or equal to 200. If you have a random glucose when the person has polyuria and polydipsia, so that person has diabetes. The other relatively new, not so new anymore, is hemoglobin A1C. It has some advantages regarding you don't have to be fasting, you don't have to do anything special. It gives you an integrated view of glucose control over a 3-month period, the life of the red cell. So there are some appealing aspects of it. And so this is also 6.5 or greater is considered diabetes. We should be getting repeat testing. So if someone has a elevated fasting glucose, for example, you get someone in, run routine labs, they come in fasting, they're doing lipids and glucose, et cetera. They're at 130, 140, or whatever it is. You should have them come back just to confirm that this is not just a blip. So this is audience question. We don't have audience response systems, but you can answer the question in your mind's eye. So in a patient with HIV, hemoglobin A1C, underestimates glycemia, overestimates glycemia, or is an accurate reflection of glycemia. Give you a second to think about it for a sec. So in the standards of care, and when you talk about using hemoglobin A1C for the diagnosis, if there is an altered relationship between A1C and glycemia, generally only plasma glucose should be used to diagnose diabetes. And it turns out that HIV is one of these situations where there is a abnormal relationship between glycemia and A1C. And so this is a study that's old at this point, but makes, I think, a really important point. So they looked at people with and without HIV, looked at the glucose and A1C. Of course, there's a relationship there. So the higher the glucose, the higher the hemoglobin A1C. But the relationship differed by HIV status. And so went off a little bit here, but if you can imagine this line being slid over, the dotted line where the corner is would be somewhere, in the 7.5 range for a glucose of 150. But it's quite different if for a same glucose of 150, it's lower in the people with HIV here by about 1 A1C point. We looked at this in the multicenter AIDS cohort study, and here you can see glucose and A1C are the axes again, people with and without HIV. You can see that since most people in the MAX don't have diabetes, so we have this huge cloud of people that don't have diabetes in the less than 126 region. And then we have people who do have diabetes, and we can see the relationship afterwards. But what we found is that we did see a discordance, and here wasn't a full hemoglobin A1C point. It was about 0.2 right at 126. But if you notice, if you look to the right of the graph, with increasing glucose, that discordance does increase. And so it can be clinically significant. And so there are a few populations where there might be significant discordance between expected and observed hemoglobin A1C, where there's an underestimation of glycemia. And there's a lab test that's helpful, and I'm throwing this question out there: which lab test is correlated with greater discordance between A1C and glycemia? ALP-FOS, AST, hematocrit, or mean corpuscular volume? I'll let that sit for a sec. And so it really is MCV. So mean corpuscular volume, here's our data from the MAX, and we looked at the risk of having clinically significant discordance, so about a 0.5 A1C point of discordance. And you can see MCV at the bottom, at the middle of this forest plot, where for each femtoliter greater than 80, you see a graded increase of discordance, or probability of discordance, or odds ratio of discordance. And so, we get MCV all the time as part of the CBC. So we don't use it really unless we're working up anemia. But this is one situation where it can be useful to just think, the A1C that you have in your patient with HIV, is it accurate, or do they have an MCV of 100, 105? That we don't really understand why, and that person is more likely to have discordance. And so why that is, I've always wanted to do a study to investigate this. I can't really get the hematologists on board, but to do a tagging study where you can look at the life of the red cell. My suspicion is that the immune activation that you have throughout the body, and particularly in the spleen, takes out red blood cells more quickly, and for that reason, you get a lower hemoglobin A1C. But that's only a theory at this point. But it's pretty reproducible. One question is whether or not these data, pretty old at this point, whether or not with modern treatment, if you still see the same impacts. That's something that clearly needs to be explored. So what do you do for screening? And so I generally do a fasting glucose. If someone is in the pre-diabetes range, you could consider getting an oral glucose tolerance test. You have to, think about what you'll do with the information. Would you just say you have pre-diabetes and talk about lifestyle changes, or talk about, if the person's obese, talk about, GLP-1 receptor agonist or metformin. I generally avoid A1C for screening. There are some factors I mentioned here at high MCV before. Other factors that came out in our study and others are those people on abacavir, people with a low CD4 cell count, those people on concomitant PIs. So that group is more likely to have this discordance. But that's not to say that if someone comes in with they have a hemoglobin A1C and it's 7.5, that person, you can be pretty confident that they have diabetes. You're more worried about the person who has an A1C of 6.2, and you're not sure if that person has HIV. You're not sure if that person really has is an A1C. If they didn't have HIV, would be more like a 6.8, or are they really a 6.2? So this is what's in the ADA regarding screening. So screened for diabetes and prediabetes with fasting glucose before starting ART, at the time of switching, 3 to 6 months after starting or switching, and annual screening if normal. And I think it depends on sort of the additional risk factors too. So we talked about who should be screened, and then the next question is, well, after diabetes is diagnosed, what should be the next steps? And so clearly lifestyle modifications are a key part of any diabetes treatment plan. So these are data, old data at this point, but rock solid, important data about the diabetes prevention program. So this outside of HIV, of course, but this is a study in which people who had prediabetes, impaired glucose tolerance, were enrolled into a study that where people were randomized to either intensive lifestyle, sort of normal care. There was a metformin arm and there was a rosiglitazone arm, which was discontinued early. This is the data from which the recommendations regarding metformin and prediabetes come from. But it's a landmark study. If you don't know it, it's one of the real critical studies to know in internal medicine and diabetes. So the DPP, it was relatively modest lifestyle recommendation. So 150 minutes a week of exercise with caloric restriction. And the goal was a 7% weight loss. And, most people, who got in the intensive lifestyle did get to that. But with that relatively small weight loss goal, there was almost a 60% reduction in the incidence of diabetes in this group. And I talk about these data to patients, telling them they may be 50 pounds overweight, but they don't need to lose 50 pounds in order to have the metabolic benefit. So a real relatively small metabolic benefit, like a 7% weight loss, even 5% weight loss, you're going to get a metabolic benefit. And so I think that's, you can, it's less overwhelming for patients to think about, relatively small 10, 15 pound weight loss rather than a 50 pound weight loss. The other part of this is physical activity. And this is, there are two parts of this. One is actually, activity. So whether it's, walking or aerobics or swimming or, dancing or whatever it is, I always, talk to people about finding something that they like to do. That way they'll stick to it. And then the other part of this is to try to resist the chair. We sit all the time. Lots of us sit, and interruption of sitting is really important in terms of metabolic benefit. And so this was a position statement from a few years ago, almost 10 years ago now, but really important in terms of the role of sedentary behavior independent of physical activity. You can have low physical activity and you can have high physical activity, but a lot of sedentary behavior. So even that sedentary behavior is not good. There we go. Okay, so we talked about lifestyle modification, and what about the first line drug? And so for a long time, when I gave these talks, metformin, undisputed world leader in of first line therapy. So it's a good drug. It lowers A1C, very long track record, no hypoglycemia when used alone, which is really important. No weight gain, maybe even a weight loss. Some data suggesting that there's cardiovascular benefit, and so decreasing cardiovascular events, cheap. The cons that we all know, the GI side effects, treatment limiting in 10% of the cases. All of the contraindications are related to people at risk of this very rare complication of lactic acidosis. the people who have low GFR, hypoxemia, decompensated liver disease, severe CHF, alcohol abuse, past lactic acidosis. In the last 5, 6, 7 years, the threshold, the contraindication has changed. So we use metformin now down to a GFR of 30, what used to be 60. So it does allow a larger pool of people to use the drug. There is an interaction with dolutegravir, about an 80% increase in dolutegravir AUC when metformin is used concomitantly. So I generally don't go above 1,000 milligrams, particularly if someone has a lowish GFR. So these things sort of, it's a renally cleared drug. So you do need to watch out a little bit. So back, 10 years ago, this was the ADA recommendation. So, metformin at the very, very top, and this is the way that it was for many years until 2003, when metformin was quietly deposed from the throne. And so why was it deposed? And so the reason being, and as you all know, is that new drugs came out that actually have more of a benefit, and particularly in specific populations. So here's the ADA algorithm, and you probably can't read it, but I'll zoom in on certain parts of it. But it focuses on lifestyle behaviors and then looks at risk factors. So on the left, you'll see cardiovascular and kidney risk reduction, and on the right, weight loss and glycemic goals. And so if you're talking about renal or cardiovascular disease, and so on this algorithm, people who have cardiovascular disease or have at high risk of cardiovascular disease, which is pretty much everyone with diabetes, we should be giving medications that we know decrease events. So this is GLP-1 RAs. And SGLT2 inhibitors as well. And then people with heart failure, SGLT2 inhibitors are definitely probably first line, although GLP-1s with the FLOW study have shown, or with the SELECT study have shown that there is a decreased risk of heart failure events as well. And for CKD, similarly, SGLT2 inhibitors are preferred, but with the FLOW study there, which was in the New England Journal last year, showed that there's a decrease in progression of renal disease with GLP with semaglutide. And so these new classes of drugs really have changed the landscape for diabetes treatment. And this is independent of the weight loss effects of the GLP-1s, which we'll be talking about in a second. So here's the roots of the quiet coup, deposing metformin. So the exenatide was the first drug back in 2005 in this class for the SGLT2 inhibitors. Dapagliflozin came out in 2012. They're talking a little bit about the incretin effect, just so you know a little bit of background about these GLP-1 receptor agonists. So it's been recognized for a long time that the insulin response to an oral glucose load, which you see, in the black line, so that is much higher than the same amount of glucose given IV. And so it had been hypothesized, well, there's something that using the gut, you get this increase in insulin. So maybe there's this incretin thing. And so I should say that people with type 2 diabetes, it was also recognized that that people with diabetes don't have as much of an incretin effect. And so, fast forward, this is 1986. So fast forward, another, these drugs have been thought about for a while. But GLP-1 was identified as one of these incretins. So GLP-1 is normally secreted by L cells in the distal small bowel and the large bowel. These are enteroendocrine cells. So they're secreted in response to a low oral glucose load. Actually, as soon as food is entered, goes into the mouth, you get an increase in GLP-1. There's another hormone called GIP, which is also released in enteroendocrine cells, but in the small bowel. And so both of these compounds cause release of insulin from the pancreas, but in a glucose-dependent way. So when you only get this augmentation when the glucose is elevated. So this is really important because these drugs can be used in people without diabetes, without the risk of hypoglycemia. And that's why, these drugs are such good agents for weight loss in people without diabetes. So we'll talk about their weight loss effect, but they don't cause hypoglycemia. And they also have, in addition to the effects on the pancreas, they have central effects on satiety, so effects in the hypothalamus. They have effects on the stomach, so slowing gastric emptying, effects on the liver. And there are GLP-1 receptors in lots of different places. So there's a lot of interest in these specific effects of GLP-1. And GIP does similar things. Both of these are broken down really quite quickly by an enzyme called DPP4. And so the half-life is really quite short. And so the drugs these GLP-1 receptor agonists are modified, so they're not broken down by DPP4. Now, DPP4, of course, we inhibit it, and it's a diabetes medication. So these are the drugs with the suffix gliptin, like sitagliptin, saxagliptin, et cetera. And so these are the incretins. Another quick cartoon of the effects. So affecting beta cell function, so glucose-dependent insulin secretion, decreasing glucagon, so which opposes insulin, so with an effect on the liver, decreasing hepatic glucose output. We talked about the effects on gastric emptying, central effects on satiety. So let's take a look at some of these GLP-1s, and this data comes from the package inserts in the registration trials. And so what you see is that with each new generation, so we have semaglutide and dulaglutides, which are the ones that are used most often nowadays. There's increasing A1C effect. There's increasing weight effect, and the weight effects are really quite impressive. And the A1C effect is important, of course. The weight effect is really important, but it's the effect on MACE, so major adverse cardiovascular events, that really is critical here. So the drug not only decreases glucose, not only decreases weight, but decreases the risk of a cardiovascular event. That's really important. And by quite a big margin. So 26% in the semaglutide post phase 4 trials. And so really important. We have a newer drug. I guess it's not new anymore, but we're using quite a bit of it. So tirzepatide, which has even better effects on hemoglobin A1C. Here you can see tirzepatide versus semaglutide 1 with the hemoglobin A1C lowering effect. So 2.3 versus 1.8. And the effect of weight, you can see the semaglutide led to about a 6.2 kilo decrease in weight among people with diabetes, whereas the 15 of tirzepatide led to about a 12.4. These drugs, the concern here is that semaglutide at the time, this was the dose that was used. Now we use 2 milligrams for people with diabetes, or 2.4 in people with obesity. Just in the past weeks, this study in the New England Journal did a head-to-head comparison in people without diabetes on the weight loss effect, confirming people's intuition that even at the 2.4 dose of semaglutide, tirzepatide 15 was superior in terms of weight loss. And I should mention the downside to tirzepatide at this point is that the cardiovascular outcome trial has not yet been published. So it's supposed to be reported on midsummer this year. So we're all sort of waiting for it. We think we know what the results are going to be based on the past what's happened with semaglutide and dulaglutide. If it doesn't show a benefit, everything's going to be reshuffled a bit. So we'll see what those results look like. So here are just thinking about GLP-1 RAs, pros and cons. Good effect on hemoglobin A1C, no hypoglycemia when used without insulin or sulfonylureas. Cardiovascular benefit, as we talked about, impacts on weight loss, liver fat, renal function, heart failure, physical function, and really the list, we're really just starting to understand, potential impacts on immune function. So, decreased systemic inflammation, which may be particularly valuable in our patient population, impact on addiction potentially. So, I think that we're really, as I mentioned, just starting to understand weekly administration, generally given sub-Q. There is an oral formulation of semaglutide, which is preferable to some people. The downside is the GI side effects. So we go up slowly every month on the dose of these drugs to try to attenuate some of the nausea, vomiting, sometimes diarrhea. There's an increased risk of pancreatitis. So I generally steer clear in people who have had pancreatitis in the past from any cause. There is a decrease in muscle mass, which goes along with the weight loss. That's probably just proportional to the weight loss. So the concern, of course, is that this, especially in older folks, that this may be a problem in terms of sarcopenia. In studies, and I'll show you some of these, in HIV, that if you look at muscle mass, you get a decrease in muscle mass, but if you look at muscle function, it actually gets better. And so there's this disconnect between muscle mass and muscle function, which is exemplified in the effects of these drugs. They are quite expensive and hard to get. Last year, this time, it's like impossible. Now the supply chains have gotten a little bit better, at least for now. It is a concern, particularly when we're in diabetes. It's actually easier, as I'm sure some of you have experienced, to get these drugs approved in people without diabetes, even though there are benefits on, say, cardiovascular outcomes, et cetera. It can be challenging. So just as far as the DPP-4 inhibitors, so not used as much, no hypoglycemia, which can be very useful. Pretty weight neutral, some effects on systemic inflammation. This was studied specifically in people with HIV. So there's a decrease in soluble CD14. The A1C lowering is a little wimpy, so about a 0.5 decrease. Some GI side effects, but pretty mild. Some pancreatitis increased risk, but it's controversial. There is this hypersensitivity reaction that people can get. It's been tested, and none of these drugs showed a cardiovascular benefit in the same kind of cardiovascular outcome trials. So that's why, if that had been different, I think we'd be using a lot more of these drugs, and they are, quite expensive. So talking about SGLT2 inhibitors, so, a cartoon of the nephron here, glucose is freely filtered by glomerulus. Most of it is resorbed in the proximal tubule, either by SGLT2 or SGLT1. So these drugs block SGLT2, so glucosuria ensues. So it's an insulin-independent mechanism. And so I have an audience response question here about the most common side effect. So nausea, diarrhea, hypoglycemia, UTI, and genital candidiasis. So I'll leave that hanging for a second. So here are the pros and cons. So no hypoglycemia, weight loss, relatively modest weight loss, nothing like GLP-1 RAs, does lower blood pressure. So in yellow here are sort of the real important ones. So preserving kidney function, even people without diabetes, decreasing heart failure risk people without diabetes, both HFrEF and HFpEF, and decreasing overall cardiovascular events. The downsides on the con side here, the A1C lowering, relatively modest. There is an increase, with the glucosuria, increased risk of UTI and candidiasis. Some, they lead to some polyuria, which can lead to dehydration. Some people who have, say, prostate problems, issues with urinary symptoms can make things worse. There is an increased risk of DKA. That's why these drugs, people steer clear in people with type 1, although there is some evidence of benefit. Some data have shown effects on bone and and amputation, and so that's been concerning. It's unclear whether or not it's sort of a blip or really something that is something specific to the drug. Only seen the amputation only with canagliflozin, and they are expensive. So when we think about diabetes, when we think about the first line drug, how should we combine the drugs? And really, this is where the individualization comes in. So you're weighing costs and risks and benefits, et cetera. So we have sulfonylureas. These drugs are super cheap. They lower hemoglobin A1C. We've been using them for a long time in studies like UKPDS, decreasing microvascular events. So, they do work for diabetic complications. There are problems. So they lead to weight gain. Importantly, though, they don't have this glucose-dependent insulin release. They're going to release insulin no matter what the glucose is. And so that's why the hypoglycemia is such a big issue with these drugs. And there's a high failure rate. So people, once if they're started on sulfonylureas, they're more likely to need other medications to control their blood sugars. So we tend to, with these other drugs, sulfonylureas really have fallen off quite a bit. The thiazolidinedione class, so pioglitazone is the only drug left standing. We did have rosiglitazone at one point. We had troglitazone at one point. But so pio is still around. So decent A1C lowering, no hypoglycemia, some suggestion of a cardiovascular benefit, good effects on lipids and liver fat, some evidence of decreasing inflammation. They actually have a very low failure rate. We used to use them or think about them quite a bit, and when we were dealing with a lot of lipoatrophy, but the effect is actually pretty modest on lipoatrophy. So this is about a 200 to 500 grams. So most people with severe lipoatrophy, from STAV eating back in the day, might have, normal amount of extremity fat is about 10 kilos, and like a 70 kilo person. A person with severe lipoatrophy may have, 3 kilos, so down like 70%. And so this amount, we can detect this by DEXA scan. There were a bunch of studies back in the early 2000s, looking at this and switches off of statine, et cetera. So there is an effect, but the effect is pretty modest and really not perceptible to the patient. The problems are that, the DPP, PPAR gamma is seen in a lot of cells. And so this is a PPAR gamma agonist. And so you have these off-target effects. So it leads to weight gain. So part of this is a fat differentiation and proliferation effect. That's why it does increase fat in people with lipoatrophy by a little bit. There is some fluid retention, and so we should steer clear in people with CHF, macular edema, which can be a problem. There's a specific effects on bone, and then there's an increased risk of bladder cancer. So we use I think there are some people who are real big TZD fans. I don't use them too often, particularly now that we have these other drugs which have other benefits. So insulin, still quite a good drug. We have unlimited A1C lowering. We can give lots of insulin to get the A1C to control glucoses. We know it has effects on microvascular events. The therapeutic window, of course, is quite narrow, so we have to be careful with it. It does lead to a little bit of weight gain. It's injectable, which can be problematic for people. This has been changing, but the costs are really quite high for insulin, particularly insulin analogs. So what I do, starting people with type 2 diabetes on insulin, I generally give bedtime long-acting insulin like a glargine or Dedamer or even NPH, and then give them a relatively small amount, 10 or 15 units, and increase by 2 or 3 units every 3 days, and have them test their blood sugar, and then get it down to 120. You can add prandial insulin, so you can get them, give them a small amount. You can even start before the largest meal to give them that prandial effect. Some people really, instead of doing multiple daily injections, want to do 2 injections a day. And I have a decent number of people on 70-30 insulin. So this is 70% NPH, 30% short acting, or 75-25 if you're using Humalog. And it's a decent way because you get both the basal insulin and the prandial insulin in a single shot. The problem is that you're sort of locked into 3 meals a day, so you have less flexibility. You want to start insulin in people who have contraindications to other medications, of course. But the 2 big populations are people with uncontrolled, very uncontrolled diabetes, because it's hard to overcome the glucose toxicity with just orals. You can start orals or GLP-1s at the same time, but at least temporarily, you're going to need to control things with insulin and then peel off the insulin slowly. And then the other population that we don't see as often now is people with very high triglycerides. So people with people with HIV anyway, people who have triglycerides in the thousands. Insulin is an important way to decrease triglycerides as well as the glucose. So what about the glycemic target? So for a long time, a lot of us have this sort of emblazoned in our minds as to what should the target. Everyone should be below 7%. And this idea of getting people even below 7% to normalize the glycemia was tested in the 2000s, early 2000s, with a bunch of randomized trials that said, okay, we know from UKPDS and other studies that it's better to have an A1C of 7.5 regarding micro and macrovascular events, as opposed to 8.5, and that wasn't, that was sort of it wasn't clear that tight control was the way to go down to 7.5. But what if we get things almost normal? What if we, throw every kind of medication at people and get their A1C down to 6? Is that going to decrease the risk of CVD events? And so the studies that you see here show, a meta-analysis of studies that specifically looked at this. So you can see the more recent ones with Accord and Advance and the VA study. And there was, with this very intensive control, about a 10% reduction in cardiovascular events. But the problem is that there was no benefit in terms of cardiovascular mortality, and there was a 2-fold increased risk of severe hypoglycemia. This is like calling 911 type of hypoglycemia. And so as a result of these studies, the ADA has taken more nuanced approach that you need individualization. So tighter control may be appropriate in someone who's younger and healthier and less prone to hypoglycemia, more likely to be able to weather hypoglycemia. And looser control in people who are older, hypoglycemia prone comorbidities. This is actually, we might want to shoot for lower in people who are on medications that are more likely to cause hypoglycemia, like insulin or sulfonylurea. So if people are on SGLT2 inhibitors and GLP-1 RAs, you can get things down, to a low level without the risk of hypoglycemia. So an important advance in the last, say 10 years has been continuous glucose monitoring, which has really empowered patients and providers. So you can look, instead of needing to do finger sticks, being able to use, a sensor that you wear for 14 or 15 days, you change out, you can get, real-time measurements of glucose that can be uploaded so the provider can take a look at what the glucose looks like. So there's, Libre, and there's Dexcom and other types of sensors. So this is what, for those of you who don't have, patients on these, you get very useful information from their download, and the upload that I can, be on the phone with someone and say, oh, yeah, it looks like you had a bad day the other day, your sugars were really high, and they say, oh yeah, I went to, whatever, a birthday party and had a bunch of cake or whatever. And so here's the report that you get. There's a lot of different information you can get from it. The information that I look at often. So the GMI is sort of the hemoglobin A1C equivalent, but over like a 2-week period when they're reporting. So in this person, it's 7.9. You look at the time in target. And there are recommendations regarding, how much time should be in target. And then you can look at the very lows and the very highs to see where things are. Here's the whole profile, but it's actually more useful to look at day by day to see exactly what happens. So this continuity you see from, say, in the top row between Friday and Saturday, he just wasn't wearing the CGM at that point. Or it used to be that you if you didn't swipe, it wouldn't save the data. But you can see this person, they had spikes with meals, so clearly needs prandial insulin. This person happened to be on dialysis, and dialysis days were worse than non-dialysis days. So very useful, great information. Much more useful than finger sticks. Finger sticks are useful, as well. And these CGMs do work quite well in terms of lowering hemoglobin A1C. And this is in type 2 patients on MDIs. And this looked at people who had more, this is a control intervention, so people got a CGM versus not getting a CGM, and looking at their A1C. These are people who had more than a 5% reduction in A1C, more than a 1% reduction. And you can see that those who got CGMs actually had better control, and they feel more in control of their diabetes because you get information in real time. So really, really important tool that we have. So what else should we be doing to prevent complications? So we think about eyes and kidneys and nerves. So yearly ophthalmologic exams with nephropathy, talking about blood pressure control, lipid control is actually important for nephropathy as well. Getting a urine microalbumin every 6 to 12 months, using an ACE and ARB in people with microalbuminuria or hypertension, and using SGLT2 inhibitors in this population as well. Neuropathy, doing foot exams in clinic, giving good instructions on foot care, particularly people who have some evidence of neuropathy. And then I send people to podiatry with people who have evidence of neuropathy, so they're not doing sort of home foot surgery to cut their nails, etc. So as far as preventing macrovascular complications, so the ABCDs are really important. So antiplatelet therapy, blood pressure control, cholesterol management, diabetes, and smoking cessation. And so the basic takeaways, I think, are underestimation of glycemia. I'd say use caution for diagnosis. It's still a useful measure for people on treatment to see, okay, they started an A1C of 8.5, where are they now? That begs the question whether in people with HIV, where you suspect this underestimation of glycemia, should we be lowering our target a little bit, depending on, if they have HIV or they don't. And, we don't have good data to support that right now. I mean, it does make, this is where individualization comes in. So if someone has HIV, they're not prone to hypoglycemia, they're on medications that don't lead to hypoglycemia, maybe you can push them a little bit harder. So lifestyle changes are really important, and that 5 to 10% weight loss, which may not be so overwhelming for the patient, is really critical. These new diabetes medications really have revolutionized the treatment. As I mentioned, metformin is not always first line, and we see the GLP-1 RAs and SGLT2 inhibitors. So A1C goals should be individualized, and here's the potential lower target in people with HIV. And then we have this multi-prong approach to prevent complications. So I think that's my last slide, and I'm happy to take any questions.
Well, thanks so much, Todd. That was amazing. I'll just get us started off. There's 2 questions in the chat. One from Dr. Post about how do we decide when to use metformin in pre-diabetes? Yep.
So yeah, good question. So it's really younger people with prediabetes, people who have additional risk factors, such as a family history, people who are overweight. So how this was determined is those people who have who participated in the DPP trial, who were more likely to show a benefit. I should say, so it's not a firm recommendation from the ADA. It's a little bit squishy. It's like a consider type of thing. But I should say that this population also is likely to be overweight or obese. And if you can get them a GLP-1 RA, I would go that route.
And Joko.
Two things. One, Todd, that was great. I'm hoping we can get a PDF of the slides, but
Sure.
I've had people on continuous glucose monitoring and they're very good with it, but increasingly I can't get it because they're, quote, not on insulin. Or I even had people on it who did better on it. The insurance stopped it saying, sorry, we don't pay for this anymore, like everything else in our life with the crazy insurances. Are there tricks or keywords like variable? I mean, is there a way to get it if someone isn't on insulin or isn't on an injectable agent? Because the patients are getting, quite annoyed.
Yeah, because they are, some people really love that feedback, even if they're not on insulin, and they do really well. And I'm sure these are the ones you're talking
Yeah,
about.
absolutely. And then their A1Cs get better and they
Yeah.
don't monitor
So,
it. And you show that to insurances and they don't care.
yeah, exactly. So one thing, and this actually is happening. I'm not sure what regulation they've seen. I'm not sure if it's on the Hopkins side or on the priority partner side, but making sure that in your prescription that you put the diabetes code in there, so that can help.
It's
And
interesting. Priority Partners has not been my issue. It's the
is that right? Other
it's
insurances.
the Blue Crosses, the Hopkins Blue Cross.
Yeah.
It's the sort of higher end insurances that are
Yeah.
starting to block now.
The other thing that sort of blew me away is that, and I think it's on the Hopkins side, I'm not sure, I can't imagine that the diagnosis on the prescription matches what's in the problem list. I know you're a big problem list guy, Joe. So even though both of them would make the person eligible, they're on insulin. It doesn't matter if they're diabetes with retinopathy or diabetes with nephropathy. If those numbers don't match, they kick it back out. So I had like 2 of those in the last week.
The other issue I have is I'm getting prior auths and I'm filling them in. And the very first question is, are they using insulin? And if the answer is no, it says do not continue.
Yeah. So it can be really tough. It can be, hopefully, as more data come out to show the benefits of these, we'll see some loosening of these.
As a follow-up in endocrinology tricks or words or coding or anything, because for most of my patients with no diabetes, but clearly risks and morbid obesity and really do need one of these injectable meds, that is where Priority Partners and the Hopkins plans all just flat, and I think all of the Medicare Advantage, all Part D plans all simply say no. You have to prove heart disease, and you can't just say, oh, I think they have heart disease. They have to actually have documentation. Are there tricks?
Not really. I wish I could say there were, that we have that, some magic open sesame code. But yeah, so I was thinking with the publication of Select, which showed a benefit in terms of cardiovascular, heart events and hard cardiovascular events, both MI and heart failure, that you would be able to use that. And there has been a little bit, sometimes it's using the medications. You may not be able to get tirzepatide, but you might be able to get dulaglutide, or not dulaglutide for people without diabetes, but even semaglutide. Yeah, it's a frustrating situation.
And
thanks. Oh, sorry. I just hey, it's Joyce. Sorry, I'm in transit, but I have had some success. I had a patient. First of all, tirzepatide is approved for moderate to severe obstructive sleep apnea. That's been helpful. And then I had a patient who I wrote for tirzepatide, and they sent it as Wegovy instead of Zepbound. So then I did a prior auth situation, and for that patient, they said they gave a phone number for him to enroll in a virtual weight loss program. And they said that once he enrolls, the weight loss program will inform the insurance company, and then it will get approved. So this is somebody not for diabetes, it's for weight loss. So, I don't know. I agree with you, Joe. As with everything, we have to call and do all this stuff, but that, at least for that payer, that was one of the issues, was what was the brand name that was being requested, and to just make sure it's obesity. And then again, for this particular payer, if the patient enrolled in a specific weight loss program, it was going to be approved.
Yeah. And along those lines, yeah, so, you know, they're definitely, you know, of course, with lots of other things, they're raising the barriers so that they wear us out, so that we don't, you know, pursue it. But one specific thing, you know, regarding, say, the difference between Zepbound and Mounjaro, like when you put the order in Epic, sometimes you think you're ordering Mounjaro, but it comes out as Wegovy and vice versa. So sometimes I put in the notes to pharmacy that it is Mounjaro. I had one patient with diabetes ordered tirzepatide, and they said, well, this is, you know, the person that they you know, they need to get Mounjaro, not, you know, not Zepbound. So putting it in sometimes helps. It's just, you know, these hoops we need to jump through are crazy.
And Todd, just going back to Joko's question about the CGMs and if you're not on insulin, is
Yeah.
there a study that was done that showed that the CGMs with because presumably they're saying you don't need this because you're not dose adjusting anything, but if actually it's been shown that people dose adjust their actual dietary intake,
Yeah.
as Joko's patients are, is there a
Yeah,
study
yeah.
that showed that they work regardless of?
Yeah, I mean, so I'm not aware of any, but someone may have different information. That would be, you know, good information to have. You know, the study that I showed was people on insulin, you know,
Right.
too.
Right, because it sounds like that's the evidence gap that would force them to do it.
That's right. Yeah, I'll take a look actually when we hang up and. You know.
That's kind of you, evidence gap. There's good evidence on the weight loss drugs and health outcomes. They still just say, sorry, no, too expensive.
Yeah. Yeah. Well,
But for your
this was-
patients not on private insurance, when they do approve it, the patient can go online and get the copay card for the company almost always. Most of my patients' copays for these Zepbound and the others have been in the range of $300 to $500 for a 3-month supply, sometimes a 1-month supply. In most cases, if they're not on Medicare or public health insurance, the copay cards cover most of that. So if you can get it, then you can help the patient.
And I've done the prescription plans, the you know, manufacturer prescription plans where they do vials instead of
The
pens.
compound pharmacies, but they're starting to.
No. This is like through Lilly.
Oh,
So it's actually pretty easy and it's relatively cheap, you know, as opposed to someone paying it out of pocket for the real deal. The compound pharmacies are different, but you can get the actual drug from Lilly through the program. It's pretty easy to do. So you can just log on to, you know, Zepbound, Lilly, you know, and you can, you know, they walk you through it.
Oh, great. Well, this is amazing. Thank you so much. And if we are able to have a PDF of the slides, we would definitely put that up on the Teams channel for anybody who's interested.
Sure.
Thank you so much for being here, and we will have you back soon.
Sure. My pleasure.
Have a
Thanks,
great
everyone.
weekend, everyone.
Take care. Bye-bye.